Okay, it's 12:17, so I'll get started. People can just keep joining as and when. Welcome everyone. Thank you so much for joining us this afternoon for Unlock the Full Potential of Occupational Health, Maximise Your Management Referrals webinar. Just a quick introduction. My name's Nicola Piper. I'm the Marketing Director here at Medigold Health and I head up our webinar programme. It's really good to have so many of you with us today. We've actually got around about 800 people registered, and that includes a mixture of our valued Medigold Health customers and non-customers too. So welcome everyone. So we're going to be looking at management referrals and how to get the most out of your occupational health provision. But we've designed the webinar so that it's useful no matter who your OH provider is. So for any non-customers on, regardless of who your OH provider is, you should find the content today very useful. We may occasionally reference certain Medigold processes, but the majority of it is just generally getting the most out of OH and your referral. It's an educational session, so I just want to point that out. It's not a service webinar, so we won't be able to answer any specific account or service related questions. So please just avoid asking them if you can. But we do welcome your questions about any of the content today. And in fact, we encourage them, please. So you've got a Q&A function you'll see at the bottom of your screen throughout the webinar. Please just drop any questions that you've got for Nikki on there, and we've got a dedicated section at the end of the session where Nikki will do her best to answer as many of those as possible. I'll do a little bit of, got a little housekeeping slide here. So as you've heard, the session is recorded, and tomorrow you'll get an email with a link to the recording as well. So you'll get a follow-up email, and feel free to share that recording link with any of your colleagues or employees that you feel might benefit from it. You're not visible during the webinar, and we're conscious that it's lunchtime, so please don't worry if you're having a sandwich or whatever, just relax and enjoy it, because we can't see you, so it doesn't matter about that. As I say, we've got the Q&A section at the end, and because this is a little bit more of a sort of different style of webinar for us, it's not actually commercially sensitive, so we are able to share the slides as well. So what we will do is make a PDF copy of the slides, and we'll also send them out with the follow-up email so that you can refer back to them and use them if you find it helpful. I'll pass over to our lovely host today. We've also got on the panel as well to help out with the Q&A section, Jay West, who's our Operations Insight Manager. Just give us a wave, Jay. Thank you. And without any further ado, Nikki, over to you.
Thank you. Hi everyone, thanks for joining. I'm Nicola Piper, the Chief Nursing Officer here at Medigold. Been with Medigold for 6 years now. Time flies when you're having fun. Clearly my picture here, I'm without the glasses on that occasion, but it's not that old a picture. But yeah, look forward to kind of talking through my slides shortly. I'm not going to go into more about me because I think that's a bit self-indulgent and I'm not very good at that. But if you want to move the slide along, Nicole, that'd be great. Okay, so the idea behind today's webinar is to try and help you get the most from your occupational health referral. So I thought I'd start off with a little bit around what occupational health is designed to do, because sometimes there are misunderstandings or you know, confusion. So I just thought I'd bring the kind of whole point of what occupational health is to life. So we're here really as a supportive function, but also as an independent voice for you. So we're here to support managers make good decisions for their employees. We're here to help the individual and the manager get them back into the workplace in a timely way with the right levels of adjustment and support in place for them. So the hope is that they can come back a bit sooner than they would if they were fully fit, to try and kind of reintegrate them into the workplace, because we all know that work is good for us, contrary to popular belief sometimes. We also provide advice in relation to somebody's functional capability and also, you know, they're kind of both psychological and functional capability. We give an impartial, objective assessment when we carry out that assessment with the individual. And also we're there to provide you with a report which should be clear, concise, and give you some guidance and advice on how to manage that person back into the workplace and back up to their full capacity. We enjoy working in partnership rather than the them and us type process, because it's really important that we understand your business and you understand what we can and can't do within that kind of relationship. So partnership working is really good. Obviously, you own the attendance management process for your organisation, but we can certainly help with your kind of reduction in that kind of attendance management field in that partnership relationship. And we're here to provide you with a report, like I said, which is independent, but with a professional stance to it, which is based on research, experience, and all the things that it takes to become an occupational health professional. Thanks, Nicole. There are a few things in occupational health that we can't do for you. And as I said just a couple of seconds ago, that's manage your absence and performance. But we can certainly help you kind of get some definitions around whether it's a person's illness that's impacting on their performance or not. So we can work towards some of these things, but we can't necessarily resolve them for you. I think one of the key steps here is we're here as your expert advisor, but we can't be the final decision maker. That sits with you and your organisation. We can't also make decisions for managers. We can give them our advice, and then it's very much up to the organisation to decide whether our advice is achievable for you as a business or not. And if it's not, all I would say is just make sure that that is written down very clearly, because they're often the kind of contentious things that crop up in employment tribunals. Just because we've said it, you don't have to do it, but it's about justifying if you can't do some of the advice we're suggesting. It's about having a good, a good auditable trail as to why that can't be accommodated. We can't give you irrelevant medical information if the individual doesn't want us to share their medical diagnosis, or if they don't want us to give you a kind of feel for what the problem is. We encourage them to try and be open where they can, because it always helps you as a manager if you've got a little bit of insight. But if they don't want to disclose, they actually don't have to. And the idea is that occupational health will help you look at what they can do rather than what the condition is behind that. Again, informed consent is a key factor. We can't act if the individual withdraws their consent. We spend a long time working around consent because it's in the individual's best interest to provide consent, but sometimes they may withdraw that consent at any point along the whole process. If that happens, we try and inform you that that's happened, and we will do our utmost to get that individual to understand why consent is so important. But if they refuse and decline, then there's not really a lot more that we can do in relation to that. Thanks, Nicole. So I always look at the case management referral as a story, really. So before you complete the referral, this bit's your part of the story, because this is the bit where you're going to tell us all about what your organisation has done for this person, what you've tried with them. So it's really important when you start to write that referral to be clear on the purpose of the referral, what you want to achieve from that referral. You need to have that kind of thing in your mind when you're completing that referral process. Make sure that the individual is with you on this journey and that they understand, why you're doing this for them, because it's about support fundamentally. Yes, there may well be some underlying issues in regards to performance and other things, but it is about supporting that individual and doing the best for that individual that you can, to keep them at work or keep them in work or get them back to work if they've been off on long-term sick. Really important to take your time to fill the form out. This is the most important bit. I appreciate everyone's busy, but this is the really key factors for us. So make sure that you've got all the information you need, and make sure you take your time. And if you can, I know it's not always feasible in the current world where we have this hybrid model of working in the majority of places, but try and bring them along this journey with you. And that then builds a relationship, which then gives the individuals reassurance. So when they do come in front of us, they're not skeptical, scared, cautious about what this process is all about. Thanks, Nicole. So some top tips to make sure this referral goes as it should. So accuracy is one. By doing things accurately, it stops any need for referrals to come back to you if we can't contact somebody. So make sure that the content is accurate. Take time, as I said, to make sure you've got the right phone number for them, the right email addresses. And I think one of the things that's really important and something that we often see is people don't always include what they've already done for that individual, and often organizations have done a lot of work before they even refer them into occupational health. So please make sure that that is included in the referral, because the way it works is if we don't see it in there, we will assume automatically that you've not done it. So if you've done a stress risk assessment, if you've made some adjustments to their work already, and already tried stuff that perhaps hasn't worked, just make sure that that information comes along with that referral, because the last thing we want to do is cause you irritation by telling you to do things that you've already done, because that actually doesn't allow you to progress that case. Really important you just make sure you include all of those things you've actually done with that individual. If you've got physiotherapy as part of your package of support, if you've already referred them into physio, make sure that's in there as well. So all of those things that you've done, no matter how small, make sure that that goes into the provision of that content. Also, highlight clearly what aspects of their role, particularly if they've got quite an unusual role where there's an expectation they can, I don't know, juggle as well as bend down and touch their toes. Make sure those kind of real key nuts and bolts are within the form of that referral, because then we can think about that generically when we're trying to give you advice around that point of that particular role. And the bit that's really important is, what is your perspective on the situation? Now, I know sometimes referrals can be a bit contentious, particularly where there's work-related stress and all those kind of things. But it really does help us to understand where this journey's gone with that individual and kind of your perspective of the situation. Because as I said at the beginning, this is your part of this kind of big picture story. We're going to have a consultation with the individual, so we'll get to hear where they've been with their health, and then obviously we'll perform our part, which is a multitude of things to advise you, but also advise the individual as well on ways in which they can look after themselves. So really important we understand your perspective on the situation. Be specific as well. Make sure you're asking the right questions. One of the things we do find that happens is if we say you can ask 10 questions, people usually aim for the maximum of 10, but actually only 5 of them are questions, and the others are often repeats or different ways of wording the question. So just make sure you're specific with the questions you want us to answer, and try and avoid duplication and unnecessary questions. If you're given a certain number, if you go to the maximum, the answers you get are probably going to be quite short. If you give us a shorter number, you're likely to get a more comprehensive answer to those really important questions that you want. Here at Medigold Health, we have a clinical duty manager that is available to all managers and human resources, people teams, ER, whatever you call your kind of structured support. And they can access our clinical duty manager between 9 and 5. And the duty manager will help them with phrasing questions, getting them into good positions in regards to not getting themselves in trouble by using incorrect wording, etc. I'm sure other providers have a similar kind of service. So check out what's available to you and utilize that service, because it's going to just ensure that you do get the right questions that are going to give you the answers you're looking for. Thanks, Nicole. So this is just a little bit more around the kind of help that a duty manager or equivalent can provide. They will help you put those difficult questions into words that keep you out of mischief. They can help you work through when the right time to refer a person is, because that's really key to when that referral comes in, so you get the maximum advice and guidance that you can. And they can also give you general health and well-being advice in regards to various things that may be going on in the work environment that you're a little bit concerned about. So a really good resource to have. As I say, we have they're called the clinical duty manager, but as I said, in other areas of different organisations who get their support from other providers, they'll probably have something of a similarity for you to access and get that information from. Excuse me. So I think, again, when the consultation takes place, the clinician has a limited amount of time to conduct that assessment, which is why, again, it's really important that you're clear with what you're looking for. Try not to overcomplicate questions and keep them relevant and precise. We've got a few examples of questions that are usually quite useful to ask, and some organisations like the Equality Act question, others don't. So it's about kind of what fits for you and how that fits. But I think this is around making sure you ask the questions that are going to give you the answers that you need to allow you to work alongside your individual, but also to progress that case thereafter. Is the employee fit to attend a meeting is a very commonly asked question, and I think very relevant if you've got a kind of a need to meet with an individual who's been off perhaps long term, or if there's any contention behind their sickness absence. 99% of the time, the answer will be that they are fit to attend a meeting. And there's some very strict criteria on why they wouldn't be fit to attend a meeting. So that's a really good question to ask if you're needing to have that kind of contact with the individual. A lot of the others about fitness for work should be a given question, because that's kind of key to what you want to know. And also, as I said, if you've already made some adjustments, we can acknowledge those adjustments and either suggest you continue, or may be able to offer some other additional support suggestions alongside that, which again is really positive from your perspective, because it kind of confirms that you're doing the right things for that individual to allow them to recover and progress through their kind of return to work. Thanks, Nicole. So I think really good to avoid losing any appointment times, etc. Really good to stay in close communication with your individuals. At the end of the day, being off sick, for example, or working in the work environment, but not being able to work to full capacity does leave people a bit anxious. They feel quite isolated if they're at home. So really good to keep in touch with them, keep them in the as I said earlier, keep them engaged with the process in regards to the occupational health appointment, reassure them I know from a Medigold health perspective, we have leaflets that can go to the individual that kind of gives them a bit of a flavour of what to expect as part of the referral process, to again hopefully reassure them, because you know, anyone going through being off sick long term or being off sick at all, and then being referred to occupational health can often bring anxiety, because they have those skepticisms about, are they trying to get rid of me? Is this about, you know, stopping me coming back to work, etc. So as much information and support as you can give that individual through this process is good. Once you're aware of when their appointment is going to take place, really useful to make sure that they can take the call or can attend the appointment, depend upon what type of appointment that is. If they can't, really good to return back to the provider or your occupational health department to kind of make sure that they can change or cancel that appointment to avoid you getting increased costs. Closer to appointments gets, the higher the cost implications to you as an organisation. So really good to make sure all the things are in the right rows to make sure that they can attend that appointment once it's made, because no organisation these days can afford to lose money for did not attend. So good to make sure that all those things are in place. They've got a space to take the call if they're in the workplace. If they're at home, they've got a good signal if it's a mobile call, etc. Do as much as you can to make sure that that goes ahead, because there's a lot of positive implications for you as a business to make sure that happens. It also means that the individual might be able to come back to work quicker too. We've got a little bit in here just kind of as an example as to our current waiting times within Medigold Health. At the moment, we've got a 7 working day waiting time to see an occupational health advisor, or an 11 working day timescale to see one of our occupational health physicians. It's, as I said, it's really key that the individual's brought along this process with us. Times can vary, again, across different providers, but I just thought I'd give you a bit of a flavour of an idea of timings from our perspective. Thanks, Nicole. Oh, I popped this bit in about GPs and consultation reports because there's a mixture of beliefs out there. My question is a GP or a consultation or a consultant report going to help in the situation? In the majority of cases, it's not always going to be helpful. We're specialist qualified practitioners who specialise in fitness for work. So a lot of the decisions we make is based on our style of questioning with that individual to be able to ascertain their capability. There are occasions where we will need to get more information from a GP or a consultation, I can't get that word out of my head now, or a consultant. I probably need to repeat that and tap my head, don't I? That's how you change your memory. But anyway, so to get these reports can sometimes be necessary. We do it as only where it's absolutely necessary. The types of situations where we may write for a report is usually based on someone who perhaps is not fit and able to communicate particularly well with us, to provide us with the information we may need. If we're looking at someone's capability and they've got quite a complex health conditions, we may need to get some more information on that front. Or if the individual is quite a poor historian and it's difficult to piece together what's going on in their world. And the final reason would be in an ill health retirement scenario where we need to make sure that the advice we're giving you is in regards to their fitness to ever return to work is very clear and concise, so that you can then look at your own kind of retirement opportunities and be able to progress through your own kind of various processes. To do the reports, we have to get consent from the individual to access their medical records, and this then comes to our clients to ask for approval to get those reports. There are a few caveats with reports. We can certainly write for them and request them. What we don't have control over, though, which is frustrating both for yourself and for us, is how long they take to actually produce those reports and how good those reports will be the other side of that. We do send them back if the reports are not good, and we do refuse to pay for those reports if the reports are not good. But this does impact on our ability to be able to kind of give you the management guidance to then manage that person. So there are a few kind of challenges all outside of our remit. As much as we'd love to have full control over it, the reality is we don't. But we will communicate with you, we will chase those reports, and we will do as much as we can. We also actively encourage the individuals to chase those reports, because they can have the pressure on their own GP to try and make sure that they do it in a timely manner. Thanks, Nicole. So obviously you've put your referral in, you've put all your good questions in, they've had their appointment with the clinician, and then you're likely probably to have communication with the individual before that report arrives back with you. Really good to check in with them, see how the appointment went, see if there was any concerns, get a little snippet of what they felt happened during that consultation. Really important, though, to wait for the report, because sometimes people think they've heard one thing and they may have heard something completely different. So always good to wait for that report before you then have that kind of formal meeting with the individual. Again, really good as a manager to have a chat with your HR, ER people team, whatever you call them in your own environment, to look at what's been recommended and what's reasonable for you as an organisation, because that's really difficult for us to be anything more than suggest a reasonable adjustment. And as I said at the very beginning of this presentation, important to, if you can't accommodate the adjustments, that's absolutely fine. We give you advice, but just document that and keep that document to hand, because that'll be useful maybe later on in the case. If you can't accommodate the adjustments, I think it's really important that that's articulated to the individual so they understand why you as a business can't do that, and for the rational reasons. So excuse me, got a frog now. So what adjustments you can do, what you can't do. HR can help you with those decision makings, particularly if there's some kind of unusual requests within there. Shouldn't be too unusual, but sometimes things do crop up. And then obviously it's good to then meet with the individual. If in the report that you get, there's stuff that you perhaps think, I'm not sure that's answered 100% my question, by all means, go back to the individual that wrote that report and just ask for that bit of clarity. We try our best to be clear, but sometimes, you know, it can get lost in translation. So don't be afraid to do that. All I would say is do all of these things pretty quickly after you receive that report. Don't leave it for months, because the nature of conditions changes so radically that, you know, if you don't do it early enough, it probably becomes a bit null and void, because people have either deteriorated dramatically or actually they may well have got better equally. So it's about kind of doing it in a good, timely manner to address those suggestions. Also, you know, at a tribunal, hopefully we don't have to go there, but at a tribunal, if you've addressed it in a timely way, there's often less criticism put into the case. So really important, keep regular contact as they go through their recovery stages. check in with them, make sure that adjustments you've done or phase returns you've done are working for them. Again, this all helps to build that relationship between you, them, and the kind of support system that you've put in place for them. If they're getting into any difficulties or they get stuck in that recovery process, then maybe that's the time to think, maybe I need to do a follow-up referral. But usually the one report you get should provide you with end-to-end support to get that person back to work. As with everything, there are exceptions, perhaps where someone's perhaps referred too early and they haven't quite had surgery or they haven't started a treatment program. It's quite difficult to predict how that should pan out. So there may well be a suggestion that you might want to re-refer that person sooner, but in the in the high percentage of referrals, you'll get all the information you need in that one touch process to be able to progress that case. That's how we work in Medigold, I have to say. And I think a lot of other providers work in a very similar route to what we do. So just to kind of give you a bit of reassurance as part of that consultation progress, because I think one of the things we often kind of get criticized for is that it often feels like you've just taken their point of the story and put that into the report when that report is processed after the appointment. So the way in which we come together with the advice from an occupational health perspective is clearly we've got your referral, which is your kind of concept of the whole picture. We've then spoken to the individual, and the way we kind of carry out our assessments, we ask probing questions that will mean something probably more to us than it will to anyone else, where we can look at what their real capability is. And we look at the whole concept of their day-to-day living as well as their work-life element too. And then we pull our conclusions together based on best practice, NICE guidance, and lots of other professional standards and guidance that we work to. At the end of the consultation, we don't only give you some advice and guidance about what might be helpful to you, but we also often give the individual some advice and guidance because they have a responsibility in this as well to get themselves better and do the best they can to get themselves better. Thanks, Nicole. So we just did a little bit of a tips to take away, and we will do this into a PDF, which again will come out, as Nicole said, with the slides. So I think key communication is always a good thing to have, keeping everyone engaged, taking away any fear factors. Be clear in your referral about what you want to gain from this, and then we'll understand that. Take your time. Accuracy is key to avoid the referral being returned, because it's, as we say, it takes time to get the referral done. So you want to do a one touch done and get that referral in. Ask focused questions, avoid duplication or over wordy, complex questions, because that kind of sometimes gets lost in translation. Use whatever support service your provision has. Obviously, ours is the clinical duty manager, as I said earlier, who are there to help support you. We want this to work, and we want this to be good for you too. So use those services. Again, to cut costs and chances of lost revenue and time, make sure they can attend that appointment and change it if it isn't something that they can attend at the earliest opportunity. And I guess, we're here to give you clinical, impartial, professional advice to help you make those decisions that you need to within the workplace to support that individual in whatever capacity that might be. Again, as I said, GP reports, not something we need very often, but when we do, it's probably best if we ask for them, because we'll then be asking specific questions as well. Whereas if they just bring a report that they've just seen their doctor, yes, it can help. But if it's something more specific, then we probably need to write that report, write the letter to request that report. Again, when you get your report back, review the recommendations being made in a timely manner, and look at having a meeting and implement those suggested adjustments as soon as physically practical. And again, after the referral, keep in touch. Keeping in touch is always key. Make sure that they're managing what they've been given to manage, and that they're progressing as they should be progressing. And only if there's any difficulty where they're stuck or the situation changes, should you need to send a re-referral in to us. And I think it's time for questions, Nicole, is it not?
It is indeed. Thank you so much, Nikki, and thank you to everyone in the audience. We've received a lot of questions and some really good ones. Just to reiterate what I mentioned at the start, this is an educational webinar that is for Medigold customers and non-customers. So there's been quite a few service-specific questions and Medigold One related questions. We won't be answering those live on the webinar. I have asked for anyone that's anonymous if they can pop their email in, and we will follow up with that independently afterwards. The questions that we'll go through with Nikki now are more kind of the general content of the webinar. So just to make that clear. There's also been quite a few questions about our duty clinical manager service. So what I'll do is put some details of that in the follow-up email as well.
Yeah, we've got a leaflet actually, Nicole. We've got a leaflet about the duty manager service, so we can probably just add that to your package. We can add that as well. Okay. Yeah. So yeah, thank you so much. There's a question here, and I do apologise if I pronounce any names incorrectly. Please forgive me. So I think it's Zenia. So this is a little bit around the kind of communication with the employee element that you covered a little bit, Nikki. Zena's asked, employees sometimes ask to see a copy of the referral, which then prevents me from being completely honest with my own professional perspective. Have you got any advice on how to overcome that? Yeah, so legally they're entitled to see it, so that we have to be quite mindful of. But there are certain terms or words that we can use that wouldn't compromise you from a professional perspective. So, you know, our duty manager would help with this. So if you're concerned about someone's perhaps drinking excessively or taking recreational drugs or something like that, where you wouldn't necessarily want to name it, but you have concerns about their kind of erratic behaviors, etc., then you could utilize terms like, you know, infrequent sickness absence. Sometimes their behaviors are a little bit erratic, because you will have had this conversation with them as a manager anyway, because that's probably what's brought the whole kind of reason behind the referral coming to the fore in the first place. So I think it's sometimes about choosing your words carefully. If we read that from a occupational health perspective, that would trigger for us the need to question some of their perhaps recreational activities within the remit of that consultation. So it is difficult sometimes, and I fully appreciate, you know, where you're coming from with that, but there is certain wording and terminology that would kind of flag to us that you've got some concerns about this person's behavior, for example, interrelated potentially with stuff that wouldn't necessarily be acceptable in the workplace.
Okay, thanks, Nikki. Anonymous has asked, this is a little bit around sort of adjustments. Are working restrictions, hours, times, etc. decided purely by the clinician, or does the employee, well, they've actually specified crew member here, but generally employee have any input on this?
Yeah, I mean, clearly within our own client load, we will have worked with them and understand, you know, what's possible within an organisation or not. But it's definitely based on the clinician's expectations of that individual versus their condition. So yes, they'll probably be able to kind of influence why, because if they say I can't do night shifts, for example, the clinician just wouldn't say, okay, that's fine. They would then dig into why they felt they couldn't do a night shift or a late shift or whatever that might be, to try and tease that understanding. And if it was just because it didn't fit their social life, then the clinician wouldn't necessarily agree with that by any means. So yeah, it's done. The clinician rules that decision, but it will be teased from the individual in the same way to understand why they believe they can't. And often we do have challenges where we say they can and they don't believe they can, but that's our professional opinion and that's the line that we stick with. And then obviously you as a manager will kind of take that situation and then make your decisions internally on that.
Okay, great answer, thank you. What about if cases, so Stevie Louise has asked about cases where an employee disputes the findings or the recommendations, often that's seen as kind of amendments. How is this reviewed from the OH perspective?
Yeah, so the way it flows is if the individual, because obviously there's a choice to see the report, and again, that's governed by the GMC. We have to offer everybody the opportunity to review their report before it comes out to management. The majority of people don't, but there are always some that will. And often they're the more contentious cases, I have to say. So what happens is those reports will come back from the individual and they'll say either, you know, I want you to change your opinion on something, which is not something we will do. If we've got the left hand instead of the right hand, then obviously we'll amend that perspective because that's factually incorrect, and as much as we try and do it perfect each time, it doesn't always happen. We are humans, not robots yet. So, I'm joking with that comment. So I think, you know, that goes back to the clinician. They have a look, they'll go through their clinical notes if they need to. If it comes back quite quickly, they'll probably recall the case quite easily anyway. And if it is incorrect, what they've said, and they can listen to the call recording, they can look at their clinical notes if there is something that feels quite ambiguous, but they won't change their opinion based upon that person's request, in essence, because it's their clinical opinion and that's their ownership. These cases that we're referring to here are often where the individual doesn't agree with the opinion, and this is often where the decision about whether to withdraw consent often occurs as well. So they'll refuse to let that report out because they don't necessarily agree with it. One of the options we sometimes say to them is, look, you know, you're going to put yourself at a disadvantage. What we can do is share your thoughts and feelings about this report at the same time as we share the report, but the report will still say what our opinion is, so that at least they feel sometimes heard, but we're not necessarily agreeing with that.
Okay, thanks, Nikki. That covers quite a few questions actually, because
Oh.
a few people have asked about if the employee feels they're fit to work and states that to the clinician, but the clinician doesn't. Where do we stand? So I think that there's a few questions around that, which is so I think you've covered it well there. When you're considering the impact, so when the report's being written and the impact is being considered, is that, somebody's asked, Lisa's asked, is that for and the impact of the employee, or is that the wider structure of the team?
So if I've got this right, so what they're asking is, do we think about the bigger picture when we make an assessment of that
Questions that sort
post?
of ask the same thing.
Yes and no, I guess, is the answer. Sorry, it's a bit splintery, this one, because you've got to focus on what that individual may need to get them back in. But we also have in our minds the bigger picture. But what we don't know as a clinician necessarily is all the kind of organizational opportunities that each business has. So we can't necessarily always take in that greater picture into consideration. We'll try, but that's where you, as in the organization that the individual's employed in, makes a decision whether this is a doable adjustment or not? Does that, hopefully
Yeah,
that
no, that does. I
answers
think
the
that's a
kind
really
of
good
two
answer. Thank
parts?
you. Let me just have a look. There's quite a few the same. There's a lot about the clinical manager. I just, again,
Okay.
so
I mean, I can talk a little bit about that
yeah, if you
generically, if
just
you
want to generally
like.
talk about that. So people are asking, I think, non-customers and customers again. So sort of if
Yeah.
you are a customer, how you
Okay.
access it,
Yeah.
and just generally what does that sort of
What
additional
does it
support look like?
give?
Yeah,
Yeah. So,
because there
so the
are a lot.
duty manager, I'll just talk a bit generically about it, and then I'll talk about how to contact for those who are our clients. So basically, the duty manager role was developed as a kind of middleman, if you like, or middle person, to kind of capture those difficult questions, how to word things, what happens if. So we kind of developed this role, and it's predominantly managed by a very senior clinician. So I sometimes do duty manager because I think it's quite nice to kind of keep in touch with reality, but also keep in touch with clients sometimes too. So the duty manager has got a plethora of experience in occupational health, usually got a really good experience across a lot of sectors as well. And they deal with a multitude of things. So there's the case management referral process where a manager don't know whether they should refer or not. And if they do, what should they ask? How do they word those difficult questions, as we talked about earlier? If somebody's suspicious that somebody's possibly up to no good outside of the workplace and it's impacting on their work. So they're the kind of, they can give that advice and guidance on how to word things better to avoid any tribunal challenges. And then there's another side to them, whereas if a manager has an individual who perhaps is suicidal and the manager feels a bit unprepared to what to do next, they can coach that manager to get that person to a place of safety. So they do that role as well. And then if somebody has a needle stick injury, so there's quite a diverse opportunity within this. They can make sure that they get the appropriate support and care according to the policies and procedures that they have in relation to that. Other common things are, somebody's come into the office with chicken pox. Is that a problem for the other people in the office? So they can be given some generic advice about that. So it can be a plethora of all kinds of things. So it's quite an interesting little daily job to do, to be fair, because it kind of challenges you in many different ways. The way in which you can access, if you are a Medigold customer, is through your customer services, through your account manager, and you can kind of either send in an email and request answers to questions, or you can ask for a callback with the duty manager. We have to be quite fluid with the callback, because obviously if we have a manager who's got someone who's suicidal, they'll take priority over the general ones, because obviously you'd want us to do that if you were that manager with that situation. So that's kind of the way in which you can access it. I mean, in our service, it's a free service as part of your contract. Obviously, I can't speak on behalf of other areas and what equivalent they have, but that's kind of where we are with that.
Fantastic.
But
Thanks,
we've got
Nicola.
that as
that's answered I hope the
leaflet,
questions that
haven't
we
we?
received.
Oh, good.
So, how many times can you refer the same person to OH?
Well, there is no limit, really. I think where we get into what I call a rotating door, it's not really, but that's my kind of analogy of it, where people come through, we give advice and guidance, they then go back into the workplace, they try some of the adjustments, some work, some don't, so they need to come back through the door for further guidance. But there becomes a point where actually you've probably been given everything that we can give you. So this is where you as a manager then have to make some organizational decisions as to whether you can continue to support this person or not, whether they need a redeployment, whether they go down the capability route, or ill health retirement if that's appropriate for your kind of policies and processes. So there isn't a bottom line. People can have problem after problem after problem, so they may not all be related to the same thing. They may be related to new problems. So you can't say you can only have 3 goes and then you're done, because they could have a heart attack the following week, which was nothing to do with what they were referred for previously. So I think it's about reading that report, reading what's being said to you. And if we kind of saying that this person is unlikely to return to work for the foreseeable future, that's usually in excess of 6 months probably. So if your policies say you can't accommodate that, then that gives you the red light, that gives you the green light to do whatever you need to do with that individual from a work perspective.
Okay, thanks, Nikki. A few people had asked something quite similar, so that's covered off a few again, which is great. Just having a look through. So again, just going back to that GP report part, Nikki, if an employee states a particular diagnosis to you that is going to impact that they're saying is impacting at work, would you look to seek a verification, or would you
No, sorry, I was a bit short. I was a bit quick there,
No,
wasn't I, Nicola? I didn't even give you time to finish. So not always is the answer to that, because you can ask questions that will give you the indication whether this is genuine or not. If we wrote for a report for every diagnosis for every person that comes through the door, we'd probably get nowhere, because on average it takes at least 3 months to get reports back. Only in the really good GPs can we get something a bit quicker. And then also, if we get a GP report, the individual has a right to see that, and they have 21 days in which to examine that report. So it's all kind of time delays, really. If people choose to tell fibs, which is probably what we're saying here, that, you know, we don't believe what they're telling us, then they can choose to tell fibs anywhere along that road, really. So I think, you know, we can ask questions that will tease out the depth of that kind of illness and the impact of that kind of illness, because that's how we're trained to do that question set that we do as part of the assessment, to tease out stuff like that, to see if this is a genuine, potentially non-genuine situation. So we wouldn't do it, otherwise we'd be here forever.
Okay, great answer. So if a timescale for adjustments, Sharon, thank you for this question. If a timescale for adjustments is provided as part of the report, but the employee continually contests their ability to work without adjustments and requests a further referral, is this considered as a change in situation, or should that go on to be another referral?
So this is probably where the individual's been given perhaps a 4-week plan of phase return, for example, if I'm understanding that question. And around week 2, they've really not progressed from where they were in week 1. So I class that as them being stuck in the recovery process. Then that would probably be a re-referral, where you would ask further questions. And I think it's really important that you put further questions forward in regards to what you've done so far, what they feel they're stuck with from your perspective, and that would probably be a re-referral into the system.
Okay, thank you. Just an admin question, actually, which I can answer. A lot of people have asked about the slides. We will be sending these round as a PDF with a follow-up email. The follow-up email usually goes out the day after. I'm just thinking, as there's quite a bit that we want to attach to this one, and the top tips, it's going to be early next week instead. So just look out for that. So that will have a link to the recording. It will have a copy of the slides to download. It will have the top takeaway, and it will have, there was something else, information about the clinical duty manager. So just putting that out there, because quite a few people have asked that question, so I thought I'd wrap that up. Do you have any criteria for rejecting or returning a referral when triaging?
Yeah. So if there's not enough information in the referral, it'll be rejected and sent back to the client. If we spot something that may be potentially contentious, where perhaps some wording's been included and we're not sure you probably want to do that, we can sometimes send those back. If you've not put what you believe the problem is, be it, they've been off sick frequently or words to that effect, we may well ask for more information on that front. But on the whole, as long as there's a reasonable amount of information in there, as I said at the very beginning of the presentation, the better you can fill that out, the better your outcome will be at the end of it. So yeah, there are a few situations where we will return it, and we'll usually give the rationale behind why we've done that.
Hopefully people that have attended this webinar, we won't be returning theirs now because they'll be taking all those tips on board.
Yeah, hopefully.
I'm conscious of the time actually, so we're coming towards the end of the session, and I'm just having a look. As I said, if anyone's got any specific service related questions, please do just drop us. You can actually email us at webinars@medigold-health.com, just so then we can triage that to the appropriate people. So I'm conscious quite a few people have raised specific questions. We don't want them to get lost, but we're not going to be able to answer them today. So just email the webinars inbox and we'll triage them out for you and hopefully get you the responses that you want.
If their name is on it, Nicole, we'll be able to respond to those, won't we? It's only the anonymous ones that we won't be able to respond to after this session.
Yeah, the anonymous, we don't know who you are.
Quite difficult.
It literally is what it says. So please send who you are in as well. Somebody else has asked here, I guess this comes back to, I think this kind of comes back to what you've just mentioned. It's just about, perhaps as a referring manager, if they're not sure the absences are genuine, how do they have these conversations when, if it's going to maybe a formal investigation or anything like that, how do they sort of communicate that when they're putting stuff in that referral if they're not sure?
Okay, so I guess it's about, X advises me that. Are you able to confirm if this is likely to be impacting on their ability to do their job? So that would be the kind of thing. And then obviously, if they're not telling the whole truth, we're going to ask them about it. We're going to delve into those questions and then we'll advise you accordingly thereafter. If at a later point they say, well, actually, that wasn't quite right, then obviously you as a manager have got your opportunity then to deal with that situation accordingly. So they've lied in essence to that. But, there has to be an element of trust, belief. You can ask them. They should, if they're reported sick, it should say on their fit note, some of the reason why they're off sick. Sometimes it says, stress at work or fractured foot or, various kind of things. Obviously, if they're self-certificating and it's frequent sickness absence, refer those in as well. Ask us about the frequent sickness absence and if there's any underlying health concerns that you should be aware of. And if there isn't, then obviously it's about poor attendance and then over to yourselves to make those relevant decisions according to policy.
Okay, thank you. And then just the final question before we wrap up, again for Nikki. So Jay, you've got off nice and lightly today, so you'll be grateful to know. It's just really about the OHA, OHP. So if a referral comes through, what do we do our end to make that decision of which clinician it goes to?
Yep, certainly. So we have a triage criteria, which most organisations will have, and we have quite strict criteria. There are some that could cross either way, to be honest with you, but the majority of the OHP referrals will be related to multi-complex mental health conditions, capability, ill health retirement, and anything that perhaps has been on long-term sick for more than 6 months, and I think that's it from the criteria. I'm just trying to pull it from memory here.
Yeah, good.
And everything else goes to the OHAs in essence. There may well be someone who's been seen by the OHA and they suggest if they need to come in as a re-referral, they may be better off going to an OHP. And that will appear within the report with the reasons why.
Okay.
But it may not be necessary if they manage to achieve what they need to achieve from the advice and guidance given.
Okay, fantastic. Well, thank you so much, Nikki and
Thank
Jay. Thank you for joining us. And a huge thank you to our audience and for being so engaged and asking lots of wonderful questions. So please do look out for that follow-up email early next week, and have a lovely rest of your day.
Thank you.
Thank you. Bye.